Okay, thank you for joining us today. I want to welcome everyone to our first STS 2024 webinar series. Today's webinar is titled Valve Surgery Education in the Era of Transcatheter Therapies. Please note this webinar is being recorded and will be available next week on the STS website and the STS YouTube channel. We invite you to become a member of STS if you're not one already. You'll enjoy a variety of discounts, benefits, and opportunities to help you grow professionally. Learn more at sts.org/membership or scan the QR code right on your screen. At this time, I am pleased to introduce our moderators for this evening, Dr. Lewis, Dr. Bagat, and Dr. Do Win. Dr. Lewis, welcome. Let me turn it over to you.
All right. Thank you guys so much for attending Valve Surgery Education in the Era of Transcatheter Therapies. I'll have the moderators introduce themselves, starting with Rohan.
Hi, I'm Rohan. I'm one of the integrated second-year residents at the Cleveland Clinic.
Hi, everyone. I'm Chi-Chi. I am an integrated third year at University of Michigan.
All right. And I am Claudia Lewis. I am a first-year attending at the Baycare Medical System, a part of Winter Haven Hospital. I recently completed my training at University of Rochester in the integrated program and an advanced fellowship in structural heart at Brigham and Women's Hospital. So thank you again for joining. We're going to introduce our moderators, our panel today.
I have the great honor to introduce my mentor, Dr. Gaurav Alawadi, who is the Helen F. and Marvin M. Kirsch Professor of Cardiac Surgery and the chairman of the Department of Cardiac Surgery at the University of Michigan. He's also the first surgeon in the U.S. to perform the MitraClip procedure.
And I'll be presenting Dr. Kaneko, who is the John M. Schoenberg Chair of Cardiovascular Surgery and the Section Chief of Cardiac Surgery at Barnes Jewish Hospital. He's also the chair of this STS workforce on technology and innovation. Next, I'll introduce Dr. Michael Mack. He is the Director of Cardiovascular Research and Cardiovascular Medicine and the Chairman of Heart Hospital Baylor Plano. He's the Vice Chair of the ABTS, past President of several societies, Society of Thoracic Surgeons being one of them, and a lead author of many of our TAVR trials.
Introducing Dr. Yoon. He's a staff surgeon here at the Cleveland Clinic and serves as the program director for both the I-6 and traditional training residency programs, and certainly has an interest in TAVR and also in lung transplant as well.
This month, we lost a pioneer in the TAVR procedure, Dr. Alan Cribier. Professor Cribier is a giant whose legacy is indelibly changed the face of cardiac disease at large. Enough cannot be said about his role in cardiovascular disease. So just want to give a moment of silence for Dr. Alan Cribier.
So in 2022, the ABTS, they updated and kind of added a cardiac pathway. So traditionally there was a cardiothoracic pathway and the general thoracic pathway. And you can see that the new one in yellow is a cardiac pathway. And there were a couple changes, but the ones related to transcatheter were that the TAVR volume, the requirements increased to 40 from 15. Interventional wire-based diagnostic procedures increased to 35 from 5. TVAR and EVAR were added at 15 from 0, and then reading TAVR, CT, TEE, and cardiac MRI that increased to 60 from 0.
So these curricular changes were made to secure our place as cardiac surgeons at the heart team table, and as a group, provide a more unbiased view on how to manage the patient in a more holistic manner. So cardiac surgical trainees who are interested in valvular heart disease should equip themselves with the skill set and knowledge to be able to treat patients with all modalities possible. Therefore, we are here today to discuss valve surgery education in the era of transcatheter therapies with experts within the field.
I'll bring on the panels and the moderators.
So I would like to start off with asking a question that's more broad. Dr. Mack, how has the landscape of valve surgery evolved since the introduction and acceleration of transcatheter therapies, and what implications can you see exist for trainees?
So the field has changed dramatically since the initial approval of TAVR in the United States in 2012. The number of isolated surgical aortic valve replacements has decreased from about 28,000 down to 15,000, and the number of TAVR procedures has increased from 4,000 to about 100,000. So right now, about 85% of all isolated aortic valve replacement is done by a TAVR approach. Now, what it's also done is the number of patients treated with aortic stenosis has more than doubled over the last decade. So the availability of transcatheter therapy has doubled the number of patients able to be treated. In mitral valve disease, the penetrance of transcatheter therapy has not been nearly as great, and there are still more surgical valve repairs done than TEER procedures. The adoption of TEER is much, much slower than TAVR. And now we're on the verge of commercialization of the first two transcatheter therapies in tricuspid valve disease. And I think we will see an increase in the number of patients with tricuspid regurgitation treated dramatically over the next couple of years.
Thank you, Dr. Mack. Shifting gears a little bit, but somewhat on the same note for Dr. Alawati and Dr. Yoon. So the training pathways, certainly with cardiac surgery, they've changed with the advent of the I6 training route. What training differences do you think are most relevant as it pertains to teaching open valve, minimally invasive valves, and structural interventions in the I6, 4-3, and traditional pathways?
Dr. Yoon, you want to start and I can fill in?
Sure. So I think that some of the changes in this area have altered some of the manners in which we train our residents and fellows. Our institution happens to be focused on the I6 for cardiac trainees. We have a general thoracic pathway that's traditional, that's 2 years. We don't have a 4+3 or traditional cardiac format. What I would say about our I6 training pathway is that the occasions in which we have to train a resident in a standard AVR, whether it's a limited skin sternotomy or a upper partial sternotomy or another format of surgical aortic valve replacement, we really sort of value those very highly in comparison to when I trained when TAVR was not an option. TAVR, I think, has taken a number of these teaching cases, which are very, very valuable for trainees into the cardiologist's hands. And yes, it is true that we have some training experience available for our trainees in TAVR, but it's a team approach. Dr. Alawati, you want to expound on that?
Sure. I think that we probably share some similar thoughts. So we have all the pathways. We're actually starting or evolving and starting a 4-3 program, hopefully in the next year. But independent of that, I think what you shared, Rohan, is the the way the board is thinking, I think, is exactly the way we need to think when it comes to structural heart disease. It is a lot more focused on imaging. It is wire skills, but it's still imaging is the absolute key. I think any of us can learn the wire skills. It's the understanding echo to the degree of a structural interventionalist. And I'll share some thoughts. Is I think any surgeon who does structural heart surgery can learn it just as well as a structural heart cardiologist. And you think about most of the structural heart cardiologists out there they're really interventional cardiologists that have evolved, and many of them haven't really been focused on echo for a long time. You know, some of them may have trained a decade before, and they are not using echo until they get into the structural heart world nearly as often as you and I do. So I think it's not a very difficult leap to say we as surgeons want to get involved in the structural heart space. We want to learn. Now, I will add, I think I'm a better surgeon in open cases because I feel like I understand echo better based on structural heart disease. And then you add in, the other components of CT measurements for TAVR, MRI, those things are really what I think the bigger gap is. I think all of those can be accomplished, with dedicated time during an I6 program. During a traditional program, you have to work at it a little bit harder. There are, as you know, some individual programs that have structural heart fellowships that I think can help as well. I hope that answers your question, or if you have others, let me know.
Absolutely. All right. My question is a little similar. Again, I'm a first-year attending, so I'm taking advantage of picking the brains of all of these experts on the call right now. For Dr. Kaneko, what are your views on training and training priorities? For instance, I know that you're a structural heart surgeon. You're also a minimum invasive surgeon and an open surgical position as well. Do you see that the training process is such that there's an ability for residents to gain competency of the three during a training program, or is it more important to accomplish the competency minimums where necessary to make a good surgeon, an open surgical AVR resident trainee, so to speak? Where do you see that kind of going with that balance?
But, and I hope you got all three during your training. All these years with I6 and at the Brigham. But, in the ideal world, if you can get all three, that's perfect. If you can do open, complex case, minimally invasive, and transcatheter therapies, I think that's the most ideal. I do tell the fellows, at the end of the day, we are surgeons. And yes, we are living in the transcatheter therapy era. And it is a little bit of conundrum because, like Dr. Max said, the number of isolated AVRs are very, very low. And those were sort of the bread and butter cases when, I was at the tail end of it. But a lot of panelists, when they were training, I'm pretty sure isolated AVR was one of the first cases that they got to do. So it is a little bit of conundrum because with the competition with TAVR, not really a competition, but more of a heart team, but the SAVRs are required to have a really, really high bar. You just cannot have mortality when we perform SAVRs. And I think that is a baseline when we graduate that we do a safe and good SAVR. I think that's sort of the baseline. And we have to build on that. We have to be able to do a lot of complex operations. We have to be able to do TAVRs. I think that probably comes next, in my opinion, because that's the ultimate minimally invasive aortic valve replacements. And then I think there are, upper hemis or right thoracotomies and now even robotics. I think those are another step that, some of the people who can check off those boxes can go to the next step. Again, that's sort of what I perceive. People might feel differently. But we really have a high bar for SAVR. And at the end of the day, we are cardiac surgeons.
Yeah, I if it's okay, I'll add also, Dr. Lewis. I think as a surgeon, as a young surgeon, right now, you and us, we're all graded by our surgical outcomes. Because the TAVR is still performed in a heart team and clips and other things are performed as a heart team, if there's a poor outcome, it's not the surgeon that's going to typically be critiqued. it's going to be the heart team decision. And so there's a little bit of safety in that mechanism. And of course, I think there tends to be, some better safety profiles with transcatheter approaches. I mean, that's what we've seen really all across the board if you pick the patients well. So we're all going to be measured by our surgical outcomes. So I completely agree with Dr. Kaneko. We have to put out a product that is safe, that can do those, those types of things in a safe way with a good outcome. And then you can continue to evolve and grow your skill sets. And the other thing you have to remember is all this is changing, right? Yoshi mentioned, he was at the tail end. Dr. Mack mentioned, living through the entire cascade, 2 new tricuspid therapies. We're going to have to keep growing, keep learning. So it's okay if we don't have all the transcatheter skills. You have interest, you dedicate time, you commit to it. You still have to keep up your open volume and skills. But the transcatheter stuff will keep getting better and better, and we'll keep getting better and better.
Yeah, I would echo some of those comments, and I would also add that I think currently any surgeon that participates in a heart team should have full confidence in their training and open surgical skills, and perhaps make sure that those are very well grounded in their training. I think some newer things that have come along, and some of the other panelists on this call have commented on this in other forums, is issues that come along with lifetime management of aortic valve disease, the ability to enlarge roots safely and be able to sort of have that at your disposal as a surgeon. I would also add the role of the surgeon also does include some of the alternative accesses, the non-transfemoral TAVR approaches and knowledge that the surgeon can bring to the heart team as well.
So I'm glad to add some comments here to the others, and I largely agree with everybody's comments, but I'll start echoing, no pun intended, Gaurav's comments about imaging. You can't spend enough time getting smart about imaging. And not only echo, but CT and MR. You need to make your structural imagers, and especially if you have interventional imagers, your best friends. It is amazing how much you can learn from them that are applicable to your open surgery. The second part is training, and we have a 5-2 program, a traditional program. And we also have structural heart fellowships. We have a surgical one, a cardiology one, and an imaging one. And so we do about 450 TAVRs a year. We do a total of 2,000 open heart operations a year. And the way all our TAVRs are done is it's all done by the fellows and or the residents. We have a surgeon and a cardiologist attending at each case, but realistically, only one of them scrubs and stands at the back table just to be sure that everything goes okay. But our procedures, if they're straightforward procedures, are all done by the structural fellows. Now, we have equal access to training for both surgery residents, interventional cardiology residents, and fellows. But to be honest with you, the folks that show the least interest in the transcatheter procedures are the surgery residents. If there's any opportunity to be in a big case, they'll be in the big case and not be in the transcatheter phase. They don't view it as real surgery. And I think that's being very short-sighted and not going to serve you well in the long term. Your attendings, be it surgery attendings, cardiology attendings, imaging attendings, are going to give you the mentorship based upon the interest you show and how much you put into it. And believe me, the interventional cardiology fellows are all over this. and they get the attention. So we have to push our surgery residents unless they're interested, and we're talking about the cardiac pathway now. Unless they're interested in coronary or advanced heart failure, and that's going to be their specialty, to step up to the table and be active participants in this. Now, that's not only unique to our institution, and that is one of the reasons that we increased the board requirements. When you are required to only do 5 and 5 as TAVRs as a primary operator and an assistant, that really is insufficient. And going to 20 and 20 is a way of forcing the trainees to get more experience in TAVR that I think is going to be necessary if you're ever going to be taken seriously. The other thing I would say is that what helps in programs like this is the partnership that develops with the structural interventionalists. I mean, it truly is a heart team. And if you spend all your time, your newest best friends become the structural interventionalists, the structural imagers, and not necessarily the other surgery trainees. So those are just a couple of random thoughts here.
I really like your last comment, Mike, about befriending your interventional cardiologist, and this is for you, Dr. Lewis, and those of you that are early in your practice. That's a great way to help build your skills, confidence, and your referral practice. If you work well with individuals and they know your skills, you're easy to find. They know how to reach you, and I think many of us have benefited early in our practice with that relationship.
And Claudine, if I can add, I think what Dr. Mack and Dr. Alawadi is saying, if you combine the two, yet you really have to show interest during your training. And, Dr. Alawadi is saying that the CT scan and the MRI and all these imaging is important. So specifically on imaging, there's some requirements that are made, but unless if you really, really spend time and really actively pursue learning how to do it, it will never happen. So you really have to learn how to do 3 Mentio when you're doing TAVRs. You can't just read the reports that people create, that industry creates and says, oh, we put a 23 Sapien 3 for this case. You can't do that. You have to go through, you got to learn how to do it from a radiologist or even the partners like interventional cardiology fellows that knows how to do it. We have a dedicated fellow at WashU, and also we have a chief resident that rotated with us. Both of them spent time to learn how to look at the CT scans. And now preoperatively, even before SAVR, they would come and say, the annulus is 320. Maybe we should be doing annular enlargements. I think those are the new level of conversations that we should require for the fellows at their stage to really obtain that knowledge. But you need enthusiasm. I think that's really, really important what Dr. Mack said.
Since the 3 moderators were all from integrated programs, we also have a wide array of time to be able to go to these procedures throughout the 6 to 8 years. But do you think that there are challenges with incorporating that into a 2 or 3 year fellowship? And do you think that with the time constraint to learn both open, be a master at that, and all of these endovascular skills and imaging, that you would need a super fellowship?
I think that it depends on where you're going to go into practice and whether you're going to practice as a generalist cardiac surgeon or you're going to specialize in a specific area. I almost think that if you're going to super subspecialize and be it, aortic or mitral valve disease or thoracic aortic disease or advanced heart failure, a super fellowship probably does serve you well if that's, and it needs to be in something you're passionate about long term. I also think if you're serious about embracing structural heart, then just doing 40 cases during your training is probably not going to make you a bona fide member of a heart team in a mid-level program. It will allow you not to be functional enough to be an active participant. But if you really want to be taken seriously, I think additional training is necessary. And unfortunately, they're all non-ACGME, fellowships right now. And there have been discussions about, ACGME fellowships for both cardiologists and surgeons, but so far it hasn't happened yet.
So I guess I would answer that question, Chi-Chi, and it depends a bit on what the practice you're looking at and what you want your practice to be in the practice you're looking to join needs and wants from you. So I think the TAVR space is different from the mitral and tricuspid space because TAVR is certainly a lot more mature. I don't think there's going to be huge advances over the next several years, aside from maybe leaflet modification, which is now coming out, and hopefully those devices will make it easier than it has been. But for the most part, that's fairly mature, and I think you probably can get a lot of those elements, in a traditional program if it's designed well. But as you already heard, if it's a 2-year program, it's hard. You want to learn how to do the complex redo that failed TAVR, because that's what's going to be expected of you, and make sure you can still get those numbers. And if you're in an environment where it's a functioning heart team and you're kind of plugged into that and you're one more surgeon out of a few, you will continue to learn those skills, the catheter-based skills. The imaging, you still should try to grow, but start that early in the process. It's going to help you in all aspects, including open surgery. I think for mitral and tricuspid, it's a bit different because I think the echo imaging is more challenging, but more importantly, the field is changing very rapidly. And that's where I do think that more specific training in that space is going to be helpful.
I would say that, I would echo what both Gaurav and Mike was saying, but I think at the end of the day, our practice continues to change. And Mike can tell you a story, where he learned how to do transeptals in your practice. Do you want to share it? You've told me that story before.
Yeah. So I went to a course at Lenox Hill doing transeptals on simulators, and it was to put in left-sided heart devices, left atrial appendage occlusion devices. And that's where I learned it. And I came back home and needed to get 20 cases to get certified. So I went to our EPs and said, will you teach me transeptals? And they said, sure, we do 2 every case. And we do, 8 to 10 cases a day. So it took me 2 weeks between my surgery cases to get my transeptal numbers. And then I taught our structural interventionalists how to do transeptals because I had learned from the EPs.
My point is that if you are willing to learn, you can learn even without doing a special fellowship. I mean, super fellowship is definitely an opportunity to learn some of these skills. But if you are motivated, there are a lot of people that are considered leaders in the field that haven't done specific super fellowships in structural heart. So it is definitely doable. Although you do need a lot of passion and energy to drive that, just like you heard from Dr. Mack. But I think
that's important, Yoshi, what you just said. All the panelists here, I'm guessing none of us did an advanced fellowship in structural heart.
I did.
So Yoshi, but still, you continue to grow, right? You just said you're doing things now that you didn't do 3 years ago, 5 years ago. So what's your advice to a surgeon that just goes out into practice to continue to grow that? How do people find the time in this environment where maybe they're expected to generate RVUs?
I think it is important to understand what is happening in the field at the moment and also understand where it may potentially go. So, talking with some of the experts is very important, but what really is the hot topic right now, I think Dr. Yun had mentioned about lifetime management of aortic stenosis. I think that's a super hot topic. People talk about, the feasibility of future TAVRs, the risk of TAVR explants. I think those are very, very hot topics. And if you are really interested in that, you can bring that to the heart team conversation with, some of the knowledge that you obtain and, make it your thing. If you are interested in tricuspid therapies, go to the courses, you want to actively participate, you want to talk to your heart team interventionalists that you want to be a part of that. And I think all of that motivation of what you want to do, but also the antenna to know what's coming and what's happening in the field is also important. That's part of my thought, Gaurav.
Yeah, I'd add to some of the comments made, and Dr. Mack's little story about how he learned transeptals, I think is a good lesson for trainees, regardless of what format their training program is, to think broadly about what skills they're really interested in acquiring and make the most of your local environment. I think, all of us have been on a couple different heart teams with regard to TAVR and other valvular therapies. And I think something you learn from working on different heart teams is that each heart team might function in a slightly different way. So you might have rotating operators. In our institution, in our building, we happen to have pretty fixed roles, surgeon and structural cardiologists that have, followed a precedent set by Lars, over a decade ago. But, you can, from different situations and with different operators, sort of learn different things and experience different things. And, I think that it's interesting. We've had a couple of I6 residents that have come through the program. They have loads and loads of open cases, and they've signed for a job, and it's their chief year. And a couple months before the end, they actually realize, hey, I got to pick up a little TAVR experience. I might have to be on the heart team. And then all of a sudden, there's this, sort of last minute rush to get a little bit of wisdom and experience with TAVR and related activities. So I think that's an interesting phenomenon I've observed a couple times.
I'll jump in and kind of add on to that. To what degree should trainees graduating in the next 10 years or so think that, to what degree their jobs will require them to be involved in TAVR or TVAR, especially, those who do academic versus those who do private?
I think, practice situations like politics is all local. And it varies from the skill sets that are present to the openness of the folks in practice, to what the skill set you bring to the table is. And I must say, things didn't evolve exactly the way I thought that they would. I thought that the ideal person would be somebody that was equally skilled in transcatheter and surgical therapy, and that there would be jobs just, begging for these people to come fill them. And that didn't turn out to be the case. It turned out both interventional cardiologists and surgeons all went through on-the-job training, and they liked doing something new, and they didn't want to give it up. And, one of the hardest jobs to find right now is a interventional cardiologist doing structural heart, because all the cardiologists want to do it. So it's much more difficult. So we have trained super fellows for, I think it's 8 years now. And the most difficult jobs to find are our structural interventional cardiologists. The surgeons don't have the trouble finding the jobs, but they're all jobs that are situations that welcome surgeons into the heart team and have a very a great camaraderie and esprit de corps, which doesn't exist every place.
I would say that, after coming to Missouri, I've seen a lot of one person or two person private practices that, the cardiac surgery service is only ran by one or two people. And in those practices, the cardiac surgeons, no matter what your training is, has to participate in TAVR because most of these centers do perform both SAVR and TAVRs. So the smaller the practice, the need for TAVR is high, which is a little ironic. It's a little different from what you think. And if you go to some of the academic centers where it's specialized, then there are people who are dedicated for TAVRs. There are people who do TVARs, but some of them don't. And I think people have mentioned it multiple times, but it really depends on what kind of practice you go to. And, it really depends on what you want to do. So you can tailor it to a certain degree at this point. Rohan, you asked us about 10 years. There could be some changes in 10 years. Right now, there are 2 operators that are required, and it specifies in the CMS that both cardiac surgeon and interventional cardiologist has to be present. But would that be still in the books in 10 years? We don't know about that. And I think that may have some implications in some of these future trainings as well. But I can tell you that a lot of the people who are really heavily invested in heart team, I think they will be grandfathered in because a lot of the cardiologists do value those surgeons' opinions and who are really invested in heart team. So I do think that people who are invested in the heart team concept will persist, will continue to be involved in the transcatheter space. I think that part cannot be understated.
Awesome. I think that also answers a question in the Q&A where they mentioned that there are some countries where the TAVR is done without cardiologists. I know that's true in parts of Canada, but the answer is it's quite feasible. And a lot of the panel here would be completely capable since they're quite motivated. I want to go to a question for Dr. Alawati and Dr. Yoon. Dr. Yoon, you're a program director at the High Volume Center, and Dr. Alawati, I know you're a mitral valve surgeon. With the morbidity of patients who have mitral insufficiency, who sometimes are semi out of bounds, pertaining to the topic of today's presentation, valve surgery in the era transcatheter, is it possible that some programs may deviate to more transcatheter modalities to manage the mitral valve, especially pertains to mitral clip, for instance? Whereas they're less so doing the mitral valve surgical repair. And with that paradigm shift, how are we then going to assure the future trainees that they'll get the exposure they need to be competent mitral valve surgeons? That's their choice of training.
I can start with maybe a part of that, and then James can fill in. But maybe a different way to ask that question is, do I think, maybe others think this too, do I think that the rise of transcatheter mitral procedures is partly because it's a lot easier? First of all, it's very safe, and it's easy to do, easy to teach, okay? It's not that hard a procedure. Yes, it's very echo-based, but echo's gotten very good. The devices have gotten better. We're getting better at selecting patients, whereas it's a lot harder to teach surgeons how to do a good mitral repair. So what we have here is, as you heard from Mike Mack, there's so many cardiologists out there that are training or trained to do structural heart procedures, including mitral clip. And there's probably fewer and fewer surgeons that are very comfortable with complex mitral repair. And so because of this imbalance, to answer your question, yes, I think at a lot of places, maybe it's not the larger tertiary quaternary care centers, but in other smaller programs, absolutely, there's a lot of creep where patients that might be considered surgical candidates at large programs represented here would be getting a transcatheter approach. So the other part of your question then is, how do you get people trained up to speed? I think some of it comes down to, being at programs where that's obviously in the thread of what they do. They're very interested in, so learning from mentors, but then also as you go out into practice, continuing, just like, you heard Yoshi mention learning transcatheter skills. All of us want to keep becoming better surgeons, better mitral surgeons, better aortic surgeons, whatever it is that we're doing, and continuing that pursuit so that we can continue to offer that. So I think that lifelong learning continues no matter what.
Yeah, I would echo those comments, and I think, I guess I am trying to paraphrase for my colleagues that are the major mitral surgeons at our center, but I think in terms of trying to master both the surgical side and have awareness of and involvement in the transcatheter side, one would perhaps presume or think that as time goes by, and if some of these larger trials show the effectiveness of percutaneous approaches for conditions like degenerative mitral regurgitation, one could foresee a future in which there is some creep of the percutaneous therapies subtracting from surgical volume. And I think from a training standpoint, as program directors and core faculty for education, we have to sort of be watching these trends very carefully. And I'm sure the board will make adjustments if it turns out that the consensus is that there should be a change in the balance of how many cases are required or what is considered state-of-the-art training in the modern day. I think trainees need to continue to push as much as they can for adequate open training. If there is a future where perhaps the overall practice in the area of mitral conditions is evolving.
Thank you.
I think the problem is that the median number of mitral cases that we do in the U.S. is 5, and I think this data is relatively old. I don't know if that number is even coming down with some of the infiltration from the transcatheter therapies. So, I think the mitral valve, one surgery that may go to the direction of center of excellence in the future, rather than some of the TAVR versus isolated SAVRs. Probably similar argument could be made about Ross. We didn't talk about that today for younger patients in aortic stenosis. I think there are some surgeries that will go towards that center of excellence concept. And, it may not be that everyone is doing mitral valve repair in the future.
So I'm curious. So there's a couple questions in the chat, and I'm curious what Dr. Mack thinks. He was very instrumental in the NCD that, in a way, protected surgeons. Got us at the table with the original trials, and the national coverage decision to get paid, maintain that heart team partner type approach. So, Mike, do you foresee a time, and how far in the future, where the question that was in the chat was that cardiac surgeons will do TAVR on their own? I think obviously the concern is, will cardiologists do TAVRs on their own? I think most of us will admit they probably don't need us for 99% of the cases, right? It's just either alternative access or when things go poorly. And there are other countries where cardiologists are doing it without cardiac surgeon even on site.
So, so Gaurav does bring up an incredibly important point. And a national coverage decision is a CMS mandate for what's necessary for you to get reimbursed. In other words, you don't have to do everything we say, only if you want to get paid. So therefore, it's a very strong stick to put practice structure in place. The TAVR did happen that way for a whole host of reasons. And it has persisted and is still in place, despite some push for the requirement for 2 operators to go away. Because as Gaurav has said, you know, for the most part, most cases can be a single operator procedure right now. Yeah, there's plenty of surgeons. I think everybody on this call that can do a TAVR just fine without a cardiologist. But be careful what you wish for, because you'll end up losing the game that way, because there's a lot more interventional cardiologists that want to do it as a single operator than there are surgeons out there. So that's not a game surgeons are going to win. Now, the tier rolled out totally differently in that the NCD for mitral reads is that the procedure can be done by a surgeon or a cardiologist, but you don't have to have both. And the reason being, when MitraClip started, it wasn't a procedure in which there were 2 operators like there was in TAVR. So we kind of couldn't go back and retrofit that requirement into it. And I do think that the fact that there isn't the surgeon requirement in there has hurt the field to some degree, and has hurt surgery participation in the field to some degree. Now, there is right now about to be issued a proposal for coverage of tricuspid valve therapies. And this exact issue is going to be at the center of it. There is a push by industry to have it the same as TEER. There are push by the societies to have it the same as TAVR. And I do think the role of the surgeon is going to be significantly defined by what comes out in the tricuspid NCD going forward. I mean, Yoshi and Gaurav, what are your thoughts about this?
Gaurav, gonna go first?
Yeah, this is a good question. I don't know the answer, and we'll have to wait and see. I guess the hope that we can argue, similar to what we saw, of course, with MitraClip, it is or different from MitraClip. It is a procedure where you, particularly tricuspid replacement, you need 2 operators. There's a position 1 and a position 2. Tricuspid TEER, maybe not as much, although it is still beneficial. And I think many programs utilize 2 operators for that. And I think that may give us a foot in the door. I suspect that'll be because the trials weren't designed to require a surgeon and cardiologist. I suspect that we're not necessarily going to win on that one in terms of getting the surgeon mandated to be at the table to get reimbursed. At least that's my opinion right now.
Yeah, I sort of think similarly to Gaurav. For the repairs, it will be very similar to M-tier. I can't see it be too different from that because the procedures are done almost in a very similar style. In reality, much easier because there's no transeptal puncture. Replacement, there's no replacement NCD in place at the moment. So I think we might be able to argue that for the replacements, surgeons may play a significant role, especially because it's a 2-man procedure, but also with all the screening and procedural process, I think the surgeons have been involved in certain cases, especially the transcatheter mitral space, mitral replacements, because they started as transapical approach. So I think you might be able to make an argument there, but definitely a tough road. Will depend on you.
So, Yoshi, that's an important point. It is highly likely there will be 2 NCDs, one for tricuspid repair and another one for tricuspid replacement. So the requirements may well be different for both, as both you and Gaurav have alluded to. James, what are your thoughts?
Yeah, we just had with our esteemed cardiology partner, Samir Kapadi, we had a challenging replacement case yesterday where I personally would argue the surgeon has a role, and there were several turns during the case where I was personally involved. So hopefully a thoughtful approach can be taken towards this that really does incorporate the contributions of the surgeons on the heart team. And as you were alluding to, I think this is sort of a very larger, more complex conversation that probably requires significant input from the societies.
The other thing that we haven't discussed is I don't know how everybody's valve clinics work, but we started with a common clinic that both surgeons, cardiologists, and imagers all participate in. And this started in 2007 when we first started with Lars doing the first partner trial. And we've kept it today. And we have an aortic valve clinic, and we have a mitral tricuspid valve clinic. And doing it all together does a couple things. It number one, keeps everybody honest. Nobody oversells what they do, and has unrealistic expectations for the patient. But everybody listens together what the patient says. And as surgeons, we tend to say, cardiologists are overselling what they do. But you sit there with a cardiologist and listen to a patient, and they say, well, I understand how good surgery is, and the results may be better 10 years down the line, but I don't want that operation. I want to go home the next day. And so it's instructive to hear, on the front end, what patients say when presented with both options and the pros and cons of both options. So if you have the opportunity in your institution of training to go to valve clinics like that, it's amazing what you can learn, not only from the decision-making approach and the imaging, but also from listening to patients.
Oh, that's a great point. Yoshi, do you and James, do you guys have clinics that function in that way? And I think I'm reading in between the lines. What Dr. Mack said is they actually go in together to see the patient. It's not like the patient's there the same day and may see cardiology first and then surgery second, or vice versa.
Yeah, we see patients in the same clinic, sort of slot, but we do see patients separately. So, the cardiologist goes in or I go in, and after you get to know them a little bit, it's very interesting. Sometimes, your trusted partners, interventional cardiologists, will go in and will recommend surgery for that particular patient, and vice versa occurs. So I think it is a, trust building block to do it in the same setting. I firmly believe, Mike, that that should be the way to go. And it's more convenient for the patients. I've seen clinics where they had to come twice, and that in itself is, very, very cumbersome for patients to have to come twice. And I think logistically it makes more sense, and it's also beneficial for us as well.
Yeah, logistically, we have a system in which the patient would see a cardiologist, structural cardiologist, as part of usually day one of perhaps a comprehensive 2-day evaluation. Typically, they'll see one of us as surgeons on the subsequent day. And, in some ways, it would be great if perhaps we could just converge and see the patient together. I think there are various factors in our logistics that sort of dictate what we have now. But I do, through the electronic record, pay very close attention to what the cardiologist has documented and think about that in my conversation with the patient. And if it's really a borderline case, then I know that several of us on the surgical side will reach out separately to one of our 4 structural cardiologists, and we're close enough physically that we can have conversations when necessary. It perhaps is not as connected as what Dr. Mack has.
But you went through Valve Clinic when you were at the Brigham. How did you feel?
Yeah,
was it different from your experience in Rochester?
So my experience at Rochester and Brigham were actually both quite an anomaly in that I had a robust exposure to transcatheter therapies and the valve team starting at year PGY2. So in Rochester, we use an apprenticeship model. So if you're with the 2 surgeons who did structural heart for that month or 3-month block, then every day that they did structural heart cases, which was usually twice a week, you would do all of the cases and you were interchanged with the IC fellow. It was a robust exposure. My understanding of Flumenzio was minimal. My understanding of like the valve team and from like a program directorship like perspective, if I was ever to assume that role at some point, wasn't quite there yet because we had a lot of robust people. I don't know if I was at that point yet. So when I did the Brigham experience, which was Michael Davidson Fellowship that Dr. Kaneko did as well, I was able to do 6 months of pure interventional cardiology, structural, from diagnostic paths to the full gamut of cases that were in trials for structural heart, which was, I think, a great exposure. In the valve clinic, I was there every time. So I was able to be a part of those conversations. So I think it's really good to have access for the residents to kind of see that. And I'm sure they'll probably choose surgery if ever given the opportunity, but to go through those options with the patients and to kind of build a story from the ground up. Overall, my exposure at the valve clinic showed me that valve surgery education in the era of transcatheter is alive and well, which again brings us back to our title. So we are wrapping up, and I want to give back a couple minutes to those who have joined us. And I want to thank extensively our panel who have given their time this evening to give their expertise and their exposure. So thank you again. And again, thank you to my co-moderators, Dr. Baguette and Dr. Dolan. Thank you.
Thank you so much to all our moderators and our esteemed panelists today for your participation and insight. Please join us tomorrow, if you speak Spanish, for the Latin Heart Rounds webinar series, Rounds on a Patient with Barlow's Disease and Annular Disjunction, tomorrow at 1 p.m. Eastern. There will be English closed captions, so even if you don't speak Spanish, you can definitely attend. The STS Coronary Conference is coming up. It returns for a 3rd year on June 7th and 8th in Miami, Florida. Early bird registration discounts are available until March 26th. Scan the QR code or visit sts.org and click on the calendar of events to learn more. Thank you so much again. Hope everybody has a wonderful night.